All right, welcome everyone. Tonight's workshop is titled Prevalence of Eating Disorders Post-Bariatric Surgery and Considerations for Providers and Individuals. My name is Danny Gillity, and I'm the Executive Director at the Eating Disorder Foundation, and I'm delighted to welcome everyone here tonight. Our workshop is brought to you in collaboration with the Eating Disorder Foundation and with one of our sponsors, Within Health. And I'd like to take a moment to share just a bit about the Eating Disorder Foundation. We're a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based organization that is now serving individuals and families both nationally and internationally. And I want to thank anyone who made a donation upon registration. We're able to provide free services because of our generous community. So thank you so much. Tonight, if you have questions for our presenter, I invite you to use the chat feature. The chat will be left confidential, and therefore I'll facilitate a short Q&A at the end of the presentation this evening. And now I'd like to introduce you to our speaker, Jessica Whately. Jessica attended Samford University, receiving an undergraduate degree in nutrition and dietetics, and completed an internship and master's of science in nutrition. She is certified as an eating disorder specialist through the International Association of Eating Disorder Professionals and provides weight-inclusive and trauma-informed care to each of her clients. She currently works at Within Health as a registered dietitian. Jessica is passionate about looking at nutrition through a non-diet and body-inclusive perspective and helps people cultivate a new relationship with food. She provides a warm and calming presence to help clients develop trust and lean into vulnerability in their healing journey. She wholeheartedly believes that food is meant to be nourishing, satisfying, and peaceful. She strives to create a weight-inclusive environment to restore a life free of body and food obsession. Thank you so much for being here tonight, and I'll turn it over to you.
Hi, thank you so much. Hi, everyone. So today we're going to be talking a little bit more about the prevalence of eating disorders post-bariatric surgery. In my work with working with individuals with eating disorders, and I've worked in higher levels of care, I found that there's not a lot of discussions about this topic. And, I'm a registered dietitian, and there's not a lot of information about how to help these individuals. And so, I really wanted to be able to put this information out there so people kind of understand how prevalent this really is, and also, just some different considerations to take in place. So today I'll go a little bit over our agenda. We're going to define bariatric surgery. I'm going to really start and tell you a little bit about the ins and outs about the surgery so you can really understand how in-depth and involved it is. We're also going to talk about the complications that may be associated with this surgery and dive a little bit too in the nutrition recommendations post-bariatric surgery and how this may affect your relationship with food. If you're a dietitian, I'm also going to talk about, different treatment recommendations and how this is implemented. Also about eating disorders and how they can get missed, and then the consequences that this can have on physical and mental health, and also dive into real life experiences as well. And I'll also dive in a little bit to some of my experiences that I've had, working with these individuals. I do want to put a disclaimer out there that, due to the nature of this talk, there may be some hard topics that we're going to talk about. We are talking about bariatric surgery, so I just want to put that disclaimer out there for individuals. So I'm going to dive into more in depth about the specific surgeries. I'm only going to go into the three most popular surgeries, but this is just going to kind of help you understand more about this procedure and what it looks like for the individual. So the first one I'm going to talk about is called what's our Roux-en-Y gastric bypass surgery. So this is when there's a small gastric pouch that is created and you bypass a portion of the stomach. You they will take the small intestine from the jejunum and attach it to this gastric pouch, and they will actually bypass part of the small intestine, as you'll see in this demographic, and they'll bypass the duodenum. The purpose of this actually is to reduce the amount of nutrients that the body absorbs. And we'll talk a little bit later, how this can create issues for some of these individuals because our duodenum really does a lot of absorption of our food. And you'll also see there's a lot of digestive juices. This is one of the more popular surgeries that we see, and you just kind of get a look and see how this alters the digestive system. The next type of surgery that is popular as well is called our gastric sleeve surgery. This is actually where there's portion of the stomach completely removed and the stomach is made much smaller. There's no alteration to the small intestine, but just to the stomach. So there's no implanted medical devices, and that's the only part of the stomach that is affected. So you see the normal stomach compared to the stomach that's been altered with the gastric sleeve. This is the third most common type of bariatric surgery. They're not seeing this one as much. There's can be a lot of complications with this surgery, but you'll see that it features an inflatable band that's placed at the upper part of the stomach and it divides it into two different parts. There's an access port and where they actually pump in saline into the band and it makes the stomach much smaller. So we're going to dive a little bit into the nutrition recommendations post-surgery. If you've ever heard about bariatric surgery, one thing that can be very challenging for individuals is there's a very specific dietary guidelines before and actually after the surgery as well. After the surgery, there's really four phases that individuals will go through. The first phase is actually a liquid diet for a few weeks as someone transitions from the surgery. This can be challenging in itself. There's jello, water, have to do clear liquid diets. Then we move on to the pureed foods. So this could be smoothies. And this is going to be probably about another few weeks, depends on where the individual is getting their procedure. Then they're going to move on to soft foods. So that's going to be bananas, avocado, salmon, roasted carrots. And then actually, they're not able to eat solid foods for about a few months. And as you can see here, they have to introduce foods really slowly. We'll kind of dive in a little bit later and talk about how this may be difficult or problematic, and also how this may impact the development of an eating disorder post-surgery. So some other nutrition recommendations that may be required of individuals is they have to wait 30 minutes after meals or snacks to consume any fluids. If we're thinking back to those pictures and those diagrams, the stomach is really small, so it actually can't fit fluids and food at the same time. So this actually has to be separated out. Also recommend to do like 6 meals a day, eating more frequently. The stomach is very small and there's a very small amount of contents that the stomach can take post-surgery. There may also be an increased need for protein as someone is healing from surgery, as well as the difficulty in getting volume of food. You're unable to use any straws to drink or drink caffeine or carbonated drinks. Foods that also may be taken into consideration for individuals can be things like nuts, seeds, popcorn, beef, pork, grapes, and granola. But this is very varied per individual and how they respond to the surgery. So now specific nutrition recommendations for individuals in treatment. As you see, there's not a lot here, and the reason there's not a lot on this slide is actually I've worked with a lot of individuals, and it is very varied on how the person may respond to the surgery. And so the dietitian really has to sit in a place of curiosity and finding a balance between medical necessity as well as challenging the eating disorder behaviors. Um, you'll have to work really closely to work with someone with individual needs. I've seen individuals who couldn't absorb protein, and so we had to get a little creative there. And I've seen individuals who had difficulties with carbohydrates, and we've had to get creative there. And so it's really hard because you can't necessarily put in the same recommendations that you would. And as the provider, you have to really sit in a place of like honoring someone's body and medical needs, but also knowing that the disorder may need to be challenged too. So it's a lot of trial and error nutritionally. Some of those same principles are going to apply. They're not able to drink fluids. So if that's something that's required in a higher level of care, that is going to need to be adjusted. They're going to have to eat more frequently, which is good because that's a lot in higher levels of care, what someone may need to do. So some of those same standards are going to apply, but I found that again, everyone is so individual. Tell me a little bit more about disordered or someone following guidelines. This is something that's very challenging, I feel like, to tease out. Someone could be following the guidelines post-surgery to a T, and it actually would meet criteria of being disordered or even an eating disorder based off the guidelines that they give individuals. And so I found that and people have a really hard time deciphering, okay, am I doing what I need to for my health? Am I doing, or, is this leading into disordered territory? We'll dig in a little bit later and talk about what are some of those signs and warnings, but this is something that, as a clinician, you have to really sit in curiosity of like, is this person taking these guidelines too far? Is it becoming compensatory? Is there a lot of body image distress, depression, anxiety? There's things to really look out for to see if these lines are being crossed. Some warning signs that we'll see post-surgery that could be risk for eating disorder, could be excessive dietary restriction. Now, this one's hard because the surgery in itself requires dietary restriction, but is someone going, above and beyond the recommendations? Is someone having binge eating behaviors? Is there excessive weight loss, purging by vomiting, or laxative abuse, chewing and spitting food? Are they having a lot of medical issues like experiencing syncope or excessive fatigue? Those are all things to really be looking at. Is body image distress high? Someone wearing a lot of baggy clothing? Some of those same eating disorder symptoms will be present, but it's going to be harder to tease out because these are going to be some of these warning signs are recommendations post surgery. One thing that has to be addressed and talked about when someone is thinking about having this surgery is the weight stigma that they may have experienced in their life. Every individual, I've worked with talks about how this was impactful to their decision. And weight stigma is the discrimination or stereotyping of people based on their weight. These individuals, they may avoid seeking and engaging in medical care. They may engage in disordered eating, which can contribute to the onset of eating disorders. They also face a lot of discrimination in healthcare. My patients have talked about going to the doctor for a cold and, being told they need to lose weight. Always, wherever they go, their BMI being handed to them. A lot of wherever they go, they're getting this advice, and this contributes to, really intense feelings of shame, you know, experiences of poor quality of life, and stigma can be an unintended consequence of these anti-obesity efforts. So these individuals, when they are having the surgery or processing this after they talk about the weight stigma they've experienced and how that has contributed to some of their development of an eating disorder. So this is a little bit more about the binge eating disorder prevalence rate in the United States. We'll dive in a little bit more to the specifics related to binge eating disorder, but 2.8 million Americans are affected by this eating disorder. And with so many individuals in America being affected by binge eating disorder, there's a lot of people looking at bariatric surgery, post-bariatric surgery, who are also going to suffer from binge eating disorder, as well as other disorders that we'll also talk about. So, it's also the most common eating disorder. So when we also take that into consideration, this has to be something that's talked about or thought about if someone's looking at this surgery because it can be a contraindication, and that's something that's important. So, one study was looking at this, and actually up to 53% of bariatric patients met criteria for binge eating disorder. This can be problematic in a lot of ways because all the surgery does is it alters the physical. There is some psychiatric evaluations, but, what can be missed in this is the psychological assessments as well as, that more intensive help with therapy. So that's something that, in this study, it found that a lot of individuals had disordered eating, if not met the DSM-5 criteria for binge eating disorder. Also, disorders that are affected in this population are anorexia nervosa, or OSFED. It is difficult to diagnose in the bariatric population due to the recommendations post-surgery. They recommend really low energy, diets, and that is hard to be able to track, is this person really restricting because that's actually what they're recommended. Eating and weight control also can promote eating disorder psychopathology. So they're required to track calories. They're monitoring their weight very closely. Rapid weight loss is really actually encouraged, and low intake of energy is recommended. We also can find that purging behaviors can be triggered due to the stomach limitations. If someone eats more than what their stomach can contain post surgery, these behaviors are actually going to be triggered. So, we also want to make sure that all eating disorders are talked about because, these individuals are seeing that other disorders like anorexia and OSFED also affect this population. But it's very, very, there's not a lot of research on in this. Like when trying to find research, there wasn't a lot out there because it's probably not being looked for. And I found, in my patients post-surgery, they may develop, anorexia or OSFED, and sometimes there's not even a body image piece present, but they actually, because the way that their stomach's been altered, they actually can't even eat enough to keep up with their nutrition needs and their nutrition intake. So that's something that I've found can be kind of difficult is that body image piece may not be there for someone, but they just are having a hard time nourishing themselves because of the surgery. Another study that I found was it explored the experiences of women who developed restrictive eating behaviors after bariatric surgery. And it talked a little bit about how weight stigma and the weight history affected their self-esteem. Also, the impacts of like how their body changed throughout their time post bariatric surgery. Also, really that internalized self-directed stigma of living in a larger body. It found that the higher a person's internalized weight bias, the greater their body image concern is, as well as depression, anxiety, stress, and low self-esteem. They also really didn't have a lot of pleasure with food. And they found that to be the case because there can be a lot of symptoms post-surgery that make it hard to enjoy food. A lot they also, talk about food in a way that isn't for pleasure, isn't for, enjoyment. It's more for really being strict with your intake because you have such small limitations within your stomach. You have to be very specific on what you eat. Another disorder that falls under the umbrella of OSFED is night eating syndrome. This can be triggered post-bariatric surgery, and this is happens when this someone is waking up multiple times in the middle of the night to eat. So this would be more than 4 times per week. So this person would not be able to function as expected during daytime hours. There's a really a disruption to the circadian rhythm, and eating is necessary for this individual to fall back asleep. They're more likely to suffer from depression and anxiety, and recent studies even suggest a prevalence of 2 to 20% in the bariatric population. For these individuals, I've seen that this can get missed really easily. This may be talked about because there's restriction during the day, but the night eating will actually persist even if restriction has decreased. And it's really hard because there will be a lack of appetite in the morning. So there may be some restriction earlier on, and it's hard to kind of get out of this pattern. Some more other general statistics. So in general, we saw this early, 9% of the US population, or 28.8 million Americans, will have an eating disorder in their lifetime. It's the second highest mortality rate of any psychiatric illness, and individuals in larger bodies have 2.4 to 5 times greater chance of engaging in disordered eating behaviors as other individuals in smaller bodies. They also may receive a clinical diagnosis of an eating disorder half as frequently as patients with smaller bodies. So, as we were talking earlier, there's not a lot of research of anorexia or OSFED in these patients, but I've personally seen it myself and I know that it can be extremely common. We also know that up to 53% of the bariatric surgery candidates meet criteria for binge eating disorder. And it's is one of the most common psychiatric disorders in patients presenting for bariatric surgery. So, looking at these statistics, it's very common in this population. We're going to talk a little bit about the complications from bariatric surgery. So, some of the most common nutrient deficiencies are going to be vitamin B12. That may be one you've heard about before. Someone's going to have to take a B12 supplement as well as a multivitamin for the rest of duration of their life. Vitamin K, vitamin A, vitamin D, copper, zinc, folate, iron deficiency, thiamine, and calcium. As you can see, a lot of nutrients, and that's because the stomach is altered and someone's going to really struggle to meet their nutrition needs with the alterations that's been taking place. So this is something that people may not expect. And they actually have to take a special multivitamin because the absorption is affected from their GI system being altered. So, and these can cost upwards of $125 per month. So sometimes that's not taken into consideration. And if someone isn't taking a multivitamin post-surgery, they're going to run into some serious consequences from nutrition deficiencies. Some other complications that can occur from bariatric surgery is esophageal strictures. This is actually when the esophagus um, c- contracts and someone actually has to go in and have surgery to have this dilated. Lots of complications with that. Dumping syndrome, this is one of the more common complications from the surgery. This is when the contents of the stomach dump into the small intestines, and we can see tachycardia, we can see sweating. There's a lot of symptoms that kind of can occur from this. Blood sugar dysregulation happens as well. And this is very unpleasant, very uncomfortable for individuals. When I've worked with individuals, we had to be really mindful of the nutrition intake. Sometimes I've had individuals who's actually even needed to weight restore, and we've had to be just really mindful of what we're giving them intake wise because it can cause dumping syndrome. Blood clots, hernias, like with the lap band surgery, the hernias can develop around the lap band. Difficulties with absorptions of medications. That's also something to take into consideration as some psychiatric meds absorb differently post-surgery, as well as muscle loss too. This talks a little bit about the malabsorption that can happen post-bariatric surgery. So most of the absorption of our food takes place in our jejunum, duodenum, and terminal ileum in our small intestine. But during gastric bypass, specifically the Roux-en-Y, the duodenum is completely bypassed. And that's where we can actually see, and as well as the smaller or lower distal part of the stomach and the proximum jejunum. And that can contribute to gastric bypass malabsorption and vitamin and mineral deficiencies, like I talked about. So, when you're altering the GI system, there can really be consequences from that. And w- I see a lot of individuals who struggle with malabsorption. They may even be eating their nutrient needs, but not absorbing them properly. So this was an individual's experience adapted from the book Anti-Diet by Christy Harrison. There's a really good part in the book that talks more about some of these consequences from bariatric surgery. She had a lap band surgically placed, and her lap band was adjusted so much that it actually made it impossible for her to swallow. And she had to be admitted to the hospital quickly because this can actually become lethal very quickly. She was in and out of the hospital multiple times and eventually had to have the all of the saline removed from the lap band. And she talks about how, she was not really aware of the consequences that can happen from this surgery and really had a lot of regret going into it. And this is just one individual's, experience post-surgery and some of the complications that occurred. So we'll talk too a little bit about the psychological assessment that will happen for bariatric candidates. So there's really not a consensus or a regulated way that this happens per center. We're talking with individuals who've had this surgery, they really it's really different wherever the individual is located. So someone may have really in-depth clinical interviews, really in-depth psychological assessments, a mental health history review, but there's also no consensus on the psychological screening tool that's used. There are some specific created for bariatric individuals, but that's not widely accepted or used. I've also had individuals who said, they were just handed an assessment and it really was like checking a box. Individuals with eating disorders may also not answer the assessment truthfully. And so that's why the really in-depth psychological assessment is important because the eating disorder could be missed just from the psychological screening tool. When one study found that most patients actually meet criteria for disordered eating behaviors, but they may not meet that DSM-5 criteria. So, that's important. But we also saw that 53% may meet criteria for binge eating disorder. So, these tools are important to be able to tease out when someone may need more in-depth therapeutic intervention before deciding to undergo a surgery, major, abdominal surgery. We're also going to talk a little bit too about some unintended consequences that can happen from the surgery. They found that actually up to 30% of patients can experience a form of addiction post-surgery. So this can happen actually because of the way that the absorption, like we talked about earlier, is altered from the stomach as well as the small intestine. Specifically talking about alcohol, um, individuals actually can be more sensitive to these substances, and alcohol is absorbed faster and reaches higher levels in the body. It actually takes longer for these individuals to clear from their bloodstream. Addiction can also happen just due to the symptoms of restriction and deprivation and the psychological changes that can occur within the surgery. And up to 30% of patients can experience the addiction, but this can also be alcohol use, gambling, tobacco, drugs, and a various wide range of addictions. One thing that was really concerning as well is in one study, 20% of people who hadn't had any issues with alcohol reported abuse within 5 years after surgery. I know someone shared a story of their sister actually passing from their addiction post surgery, and she never had a history of any addiction use. And so when you're altering, some of these absorption pathways, this may not be thought of, and that's important with those psychological screenings to be able to see if someone is a higher risk of developing addiction, if they have co-occurring psychiatric conditions, but they also may not, and that can develop as well. Digging a little bit too into some of the outcomes of the surgery, For individuals as well, risk of suicide is up to 8.7 times higher in women and 5.5 times higher in men. In one study, they found that 50% regained some of the weight back that they originally lost. By 4 years, 63% have regained some of the weight that was back. And part of this is due to some of that metabolic adaptation that happens. Let's go back to when we talked about those nutrition recommendations post-surgery. People are eating really low energy for very extended amount of time. Well, that's not something that's going to be sustainable. And so, these individuals may see that, you know, the weight loss that they initially found is actually not something that is maintainable because of the way that it had happened. Um, and they're found too that outcomes versus expectations for people can play into the risk of suicide. People may go in really expecting this to be a fix-all or not have any complications. That may not be the case for individuals. And so that's really important for people to really understand and really put in check their expectations. About 7 to 15% will also need revisional surgeries. So, let's thinking about Sarah Harry's experience from anti-diet, she needed a revisional surgery because of the impact that the surgery had on her. So that's another recovery period. That's another, 2 months of really strict guidelines nutritionally. And that is very challenging for individuals. A large scale study in 2005 found that 4.6% of people actually died within a year of surgery. So that's the most serious complication. And there's not a lot of long-term studies following these individuals either. And so that's not something that's talked about as well as, there can be this consequence in addition to, those outcomes that we already talked about. Digging a little bit into some myths that I've kind of found working with some individuals is there's very strict guidelines nutritionally, as we've talked about. And so some people, were really not, there's a lot of fear around food. And, some myths that I found is like you can't enjoy sweet foods after the surgery. These individuals are told, that they may never be able to eat sweet foods or desserts. And, I found that that's really varied per person. In pleasure and enjoyment's a very big part of a relationship with food. And that also can contribute to some of those binge eating behaviors if there is no, if someone is not able to, have a really balanced, nourishing relationship with food. So, we maybe get creative around how we, put these foods in place. But, it is a myth that these individuals can never have sweet foods. You must always stay on a low energy diet. That's also not necessarily the case. These individuals, that's not going to be sustainable forever. And as we'll see, it's going to create a lot of nutritional deficiencies if someone is on a low energy diet long term. So that I've been able to get people up to the amount of food that they've needed. It's had to be sometimes really creatively, but we've been able to do it so that you can enjoy all types of foods from different food groups. Actually, again, this really varies per person. Some people are gonna maybe tolerate some foods better than others, and it's a little bit of trial and error of really seeing of like, okay, what foods can I enjoy? What foods are going to maybe upset my stomach? Are any foods going to cause dumping syndrome? This is something that again, is just gonna have to be really varied per person. Another myth is you cannot have carbohydrate foods post-surgery. This is a food group that's really demonized in this population. But we also know that carbohydrates are really important for blood sugar regulation, you know, really important for, it's the primary fuel for our body, glucose, it's the energy that our body uses. So this is something that actually does need to be implemented and is important. And so as a dietitian working with individuals with eating disorders post-bariatric surgery, I have to really act as a liaison and really help individuals repair maybe some of the disordered thoughts that they've had with food or disordered relationship that maybe they developed post-surgery because of the really strict guidelines. So really helping someone kind of, again, find that middle ground, find that balance between I'm honoring what my body needs and the medical needs that my body has, but also, the pleasure and nourishment of food as well is important. And so those have to really blend together. So we'll see a lot of these can really, as a dietitian, you can really help to, debunk some of these and also just help the individual just to really see, and learn to begin getting back some of that body trust. So Brie Campos is an individual. She's a fat positive therapist as well as a body image coach. And she has some really good resources on her page about this. You'll see below her Instagram. But she is an individual who had weight loss surgery, and she talks a lot about, how this impacted her on her page, as well as, some different considerations and different things for individuals to consider and take in place. So on her page, she talks about three things that she learned 10 plus years after the surgery. And she learned that weight regain is likely, and she experienced this for herself. And if weight regain happens, a lot of the times that blame is put back on the individual. But again, we talked about some of those metabolic adaptations that happen, and a lot of people don't know that weight regain is really likely, and that can be really devastating. I've worked with individuals who went into medical debt to get this surgery and, found themselves regaining some of the weight back, which was very challenging, and brought up a lot of shame. She also talks about how body image can't be fixed by just changing your body. I think that's really difficult for individuals to understand is like they think maybe going into the surgery, their body image will be changed. And we know body image is so much more complex than just a number on a scale. And at the time when she got the surgery, she didn't know that it was going to have this effect and really thought that her body image would heal and that she'd have this different feelings about her body. She also wished she was informed about the impact this would have on her years later. She reports she doesn't know how many people who haven't had long-term issues, when she's talked with other individuals who've had this surgery, she's found a lot of people, struggle with long-term issues. There's even some that I haven't talked about. And there's a lot of really, when you again alter the digestive tract, there's a lot of things that can happen and a lot of side effects that can go in place. So she actually has this really good handout for providers when you're working with individuals who are maybe thinking about bariatric surgery, maybe it's even post-bariatric surgery. And so this is a free resource that she has for clinicians. But she tells you to get really clear with the individual that you're working with. So clearly state your privilege without evading the individual's pain or position. The goal is actually to acknowledge your privilege, but also acknowledging your clinical thoughts. Every individual does have full body autonomy, but it is important, you're the clinician, you may have experience, I have experience with patients, and so I can bring that into my sessions. And so she gives like some dialogue that you can use of like, you're absolutely right that I have privilege. I need to hold that, but also want to make sure we assess the risks and costs of surgery. Can you explore that with your patient if, that's something that they want to explore? We talked about the multivitamins. That could be $125 per month. Is that something that someone can afford? In a lot of cases, that's not an extra expense that someone may afford. There's also specialty foods they may have to buy. There's different costs that can happen and occur, from the surgery. So, two, you want to listen. So, listen to your client's discomfort without co-signing their often temporary solution. So, you want to honor their experience, but also read about their treatment goals. Are they in the treatment currently of their eating disorder and they're thinking about this surgery? Really validating, you know, this discomfort sounds so painful. I want you to know I hear you, and I'm just curious how bariatric surgery works with or against our treatment goals. You also want to explore the client's reasoning without leading your question. So your goal is not to convince your clients. Your goal is to poke holes in maybe some distorted logic. So, motivational entering. How might you feel if you do this surgery and you don't heed the results you desire? What evidence do you have that this approach is reliable? This if you're a client thinking about the surgery, you can use these for yourself, get really clear with yourself, really clear with your goals. It's really important to explore your motivation. Analyze underlying motivation, even if you can't relate. So, understand how maybe they've been masking dysfunction. You can even say, I have to be honest. This maybe feels like a sudden decision. Can you help me understand how we got here? What has this desire put this desire into action? When I've dug into this with individuals of when they've maybe nutritionally, they're like, hey, I need this surgery. They may open up and talk about, maybe they had a bad experience at the doctor that day. Maybe, it was something that was actually recommended to them, a surgery that was recommended to them. So that's important to make sure you think through all of those pieces of analyzing, exploring, listening, and then remain unwavering in your clinical position, even if there is resistance. So, explore what the client may be seeking, you know, ensuring, making sure they know that you'll honor their autonomy, but it also would be a disservice if you didn't explore it with them. So, leading with curiosity is really important because these individuals have themselves experienced probably a lot of weight stigma. There can be a lot of grief that maybe the individual has to hold as well. So, as the provider, it's really important to hold space for the individual to be able to think through this and process with a safe individual. They may not be getting the full picture from the bariatric surgeon, or, I went just doing some of this research. I went in and one website had just a calculator. It's like, you qualify for surgery. And so it's important, like, this is a really in-depth surgery. And so it's really important to make sure that you're thinking through um all of the ins and outs and how to really overcome some of these barriers. Some reminders for clinician, your client's lived experience matters. It's really important to not minimize their experience. You know, they may have a lot of experiences in their life that, and they probably do, that have brought them to this point to consider this. And that's important to make sure that that's not discredited. I think, we may brush it off super quickly or like, oh, you don't need that, or, but it's important to hold space for the weight stigma or the things that have led them here. Wherever they face, they're maybe faced with a world that's not created for them or for their size, and it's important to not minimize that. Also, it's important to note that, their body grief is unavoidable. They may be in this bargaining phase still, and we need to highlight the path towards acceptance, which means they'll have to grieve maybe this ideal, or maybe they were hanging on to the hope that bariatric surgery was going to be the fix all or cure all for what they were really hoping in their life. And that's really hard. And, I find myself just having to sit in this, and sometimes I, want to jump in and fix it. And that's not something that we may be able to do. And so just like going back to those clear guidelines, like this resource from Bree, just is really helpful as a clinician to be able to just really sink in yourself and really see, okay, what do I need to take into consideration? How do I help this individual grieve? As a dietitian, like holding space, maybe holding your privilege, helping someone nourish throughout this is really important. There's also so many things on the stove in a session, especially working with an individual with an eating disorder. So, you know, sometimes it's easy to miss or put things on the back burner, but don't miss, you know, this. Or if someone maybe just like slightly says this, or in a quick moment, like this is important not to miss, and make sure you're coming back to this. And um, it's important to kind of bring up because individuals may even stop sessions with clinicians or with dietitians if, they want to pursue this surgery. So it is important to make sure to not let that conversation be missed, or not, go into this making sure that, you're talking through the ins and outs just from your clinical experience. And so it's a hard place to sit in, of honoring someone's body autonomy, but also your clinical gut, your clinical knowledge as well. So, just trust yourself and your clinical abilities. Like, it's going to be important for you to be able to really sit in that place with the individual and know, like, it's a really vulnerable place someone is if they're talking to you about that. And so it's really as an honor as a clinician to be able to have an individual, maybe they're willing to talk to you about this, even if they know maybe your standpoint, maybe you're weight inclusive and they know that. But I often find if, individuals wanting to talk to me about this surgery, they kind of know maybe where my stance is going to be, but they want another opinion and they want to really talk this through and not make a really rash decision. And so we can kind of be that safe space for individuals to be able to just really process and think through all the things that they need to. Questions for individuals if you're thinking about pursuing this surgery and maybe have a history of eating disorder, or maybe you don't even have a history of eating disorder. Um, it's really important to like really, even using that research from the clinicians, getting clear with yourself. Will the surgery work with or against the goals that you currently have? What are some risks that could kind of happen you know, if you end up taking the surgery? Do you have the financial resources that you need for some of the costs that could occur? Costs from the surgery, even with insurance coverage, there's going to be costs associated. If there's not insurance coverage, there's going to be really a significant cost there that you could occur. So it's a really important to make sure you get really clear with yourself about your goals. What's the total cost of everything before and after? Does that make sense with your life? You know, I've had individuals who've paid out of pocket for this surgery, and that they've gone into extensive debt, and that it has needs to be something that's really taken into consideration. If there's an eating disorder present, that's going to be a little harder to be able to make that irrational decision without, some of those ED thoughts or ED rationale kind of coming into that. So that's really important consideration to take into place. Also thinking about, what are your goals for your health? You know, can you meet some of those goals meeting with a dietitian? Do you want to improve your blood pressure and your A1C? Like, there is ways, that we as clinicians can help you meet those goals that maybe doesn't have to go to the extreme of altering your stomach. You know, can we really get creative and really think together of the ways that maybe we can accomplish some of your health goals? Also thinking of like getting real with yourself. Is there any like diet culture or weight stigma or any of those pieces playing a role in your decision as well? And can you meet with a clinician? Can you meet with a dietitian and maybe really talk through some of that body grief that you might be experiencing? It's really important to make sure you really if this is something that you're looking at pursuing, really thinking through this. If this, this is something you've already done, there's no shame. And that's something you can process as well. Bree really goes to and talks a little bit more about like the process that she's gone through, the grieving process, and all that been through. And now, being a body image therapist and fat positive therapist, and the education that she's been able to do and healing she's been able to do with her body image. So again, questions to ask yourself is, you know, really get clear with your intentions. Also think through the consequences that could kind of happen in this with this surgery. In this presentation, I really wanted to make sure I kind of highlighted maybe some of the things that people don't often think about when they're thinking about bariatric surgery. And some of these things can often be missed. And so it's important to make sure that you're asking the questions, you're sitting down with people. And it's important to bring issue to these light to these issues too, because eating disorders in this population are often missed and underreported and also understudied, so that's something important too to think about as well as like the risks that you could be taking going into the surgery. So thank you everyone for listening to the presentation today. I hope you can take some good takeaways from this and maybe some resources as well.
Thank you so much. That was so informative and so incredibly helpful. And there are a few questions. So we have just a few minutes. And if we don't get them to them all, please send me an email and I'll put the email in the chat and we will email them over. So this person is curious if there has been any connections made in research between night eating syndrome and the prevalence / popularity of intermittent fasting.
Ooh, that's a good question. There's not a ton of research in itself on night eating syndrome. I haven't come across any with intermittent fasting. However, these individuals will naturally intermittent fast because they'll wake up with a lack of appetite. So they're going to restrict during the day. And then a lot of the eating will occur later at night or even in the middle of the night. But that would be really interesting research. But I have not found any.
Thank you for that. So, and this person writes, how do we support individuals living in larger bodies, considering bariatric procedures a way of dealing with medical conditions, especially cardiac, respiratory, sleep conditions, etc., in which their medical doctors are strongly advocating for a significant reduction in weight? The pressure to comply with the doctor's orders can feel overwhelming at times. They continue to say many of these individuals find themselves wrestling between living a happy and healthy life and finding space for there to be an intersection in the spectrum, what allows for a happy, healthy life in a larger body. It's just kind of your thoughts on that in general, of just the pressures of the medical system around all this.
Yeah, I think this is particularly one that's really challenging. I know when this is recommended to a patient, it's typically recommended somewhat strongly. And that is difficult to navigate because, there can be a power dynamic with medical providers and feeling as if like you're going against that. And there was a dietitian who was talking about how she used to be a bariatric surgeon and is now a weight inclusive dietitian. And with the surgery, yeah, there might be improvements in cardiovascular systems, blood pressure, maybe even glucose levels, but that comes with other consequences. And so someone has to really weigh that of like, can these other consequences, outweigh
Mm.
the improvements in the cardiovascular system? Can, you know, there be improvements made with their health without going to such drastic lengths? But it's really important, that individual is probably really sitting in maybe a lot of body shame. And it's important to hold space for them to be able to process that.
You. Okay, so another question. This person has heard something about a phenomenon regarding type 2 diabetes reversing um, gastric bypass. I'm curious if you've seen this and whether it ever returned. I'm curious if the initial reversal could be related to any of the vitamin mineral difficulties. I don't know if you understand. Yeah.
Yeah. So that they do see sometimes a reversal of type 2 diabetes with the surgery. It probably could be due to just the significant, you know, decrease in just glucose in general. Um, but often this can be a rebound effect, but it also could come at the consequence of like malnutrition. In these individuals, I've seen a lot of individuals who have ended up losing a severe amount of weight and they may not be diabetic anymore, but they're dealing with severe malnutrition, electrolyte imbalances. Like there's a lot of other co-occurring medical things that can happen. So it's hard because there may be some things that improve, but there could be a lot of consequences that come with that.
Okay. One more question. So how do we know who to trust? The bariatric surgeon who says not to go over 1,000 calories a day and counting every calorie that enters your mouth, or the nutritionist who's treating me for atypical anorexia, who has me on a detailed meal plan that very well surpasses what the surgeon says? I know you can't necessarily answer that, but just
Sure.
some insights on that.
Yeah. Definitely can't, give you the answer there. And I think that's hard because it's like I've had that same conversation with someone of like, yeah, the surgeon told me to eat 1,000 calories. I think if we go back to the basics, a human can't survive on that little of energy forever. And so that's important to take in consideration of like, oh, that's such a hard place to be like your surgeon saying something, your dietitian saying something, and listen to your gut. What does your gut say? I think if you really look into that and dive into that, you're gonna find your answer. A bariatric surgeon you don't spend much time with. Your dietitian, you're probably developing a relationship, and hopefully there can be some rapport built there.
Well, thank you all so much. Again, this presentation has been recorded and you can watch it on our YouTube channel. We'll also send it out to everyone who registered. So thank you again. And yeah, Jessica, we couldn't be more grateful for your time and your expertise. And please follow up if you have questions.
Thanks, everyone.